My name is Karla Lužajić. I'm a fourth-year student at the Faculty of Medicine in Zagreb and an assistant for public health for Croatian Medicine Student International Committee. I'll be moderating our meeting. The Access to Medicine movement has been an important driver of a wider health movement for health for decades. Thanks to this movement, important breakthroughs have been made when it comes to, example, access to HIV/AIDS treatment, but also in the way we think of the pharmaceutical industry, intellectual property, and trade. Even though the movement grows stronger all the time, barriers to access to essential medicines remain present, especially in the countries of Global South, meaning that people living outside of majority of rich states cannot access key medical products because of their price. When the COVID-19 pandemic started, governments and health officials all around the world have called for a response based on international solidarity. The World Health Organization has echoed their calls and extended them to include sharing of the knowledge and data development through the research of COVID-19 technologies, medicines, and vaccines. Nevertheless, recent announcements about the inequitable distribution of vaccines between the Global South and North indicate that our global response may not be as solidary based as we'd like. According to a letter published by the World Federation of Public Health Associations, 80% of the vaccines doses that could be produced during 2021 have already been committed for high-income countries, which make up 20% of the global population. Naturally, this is a heavy blow to low and middle-income countries, whose population, if this happens, will once again be left behind for the sake of the profit of a few shareholders of big pharma companies. To understand better why this is possible at all and consider some of the options available for future actions, we're joined today by three speakers from the Access to Medicine movement. Lydia is a medical student and European coordination at Universities Allied for Essential Medicines. She's a strong advocate for equitable and affordable access to medicines and vaccines. Today, Lydia will give us an introduction to the Access to Medicine movement and take us through Universities Allied for Essential Medicines efforts to make essential medicines accessible to all. Kajal is a lawyer who has been working on different aspects to access to medicines since the early 2000s. She has worked particularly closely with India Office, the Delhi Network of Positive People, and the People's Health Movement in India. Kajal will explain the international context in which the distribution of COVID-19 medical products is being planned, highlighting the impact of trade and intellectual property provisions. Julie Stindam is an organizer and coordinator of the Right to Cure European Citizen Initiative. Previously, she has worked for a number of civil society organizations, including the Belgian organization Viva Salud. Julie is here to talk to us about the Right to Cure campaign and its importance for involving Europe in solidarity and social justice-based response to the COVID-19 pandemic. We will first listen to all three interventions and take about half an hour for discussion after all our speakers have finished their introductions. If you have any question, please type it in the chat box. My colleagues will collect all the questions and we'll do our best to go through all of them. And also, if you want to use option raise hand, you can if you would like to ask the question yourself during the discussion. So you can just click on the hand option in the toolbar below and keep it raised until we call your name. Let's now start with Lydia's intervention.
Hi, let me just share my screen. I hope you can all hear me loud and clearly. Okay, you should now be able to...
Lydia? Sorry, we can see the screen, but we can't hear you really well. So.
Can you hear me now? Is it better now?
Now it's perfect.
Perfect. Okay. So, hi, I'm Lydia. I'm a third-year medical student in the UK, and I am an advocate for UAM. UAM stands for Universities Allied for Essential Medicine, and it is a student-led organization that is represented worldwide. We fight for global access or equitable access to medicines all over the world. I will now start by explaining some basic concepts of access to medicine, such as what is drug development, how is it developed, how does patenting of drugs work, and so on. Then I'll continue by telling you a bit about the historical aspects about access to medicines and also how UAM was founded and what we're fighting for. Then I'll try to give you an introduction into our areas of focus, followed by an outline of the organizational structure, and then a broad overview over our current campaigns, especially now during the COVID-19 pandemic. So I'll start by kind of trying to define what patents are. So as you might know, patents answer protect inventions from being reproduced or sold by other people. So for example, if you produce a drug, you will then patent it to prevent it from being produced, sold, and made profits from by other manufacturing bodies, such, for example, other pharmaceutical companies. Now, if you hold a patent, this will be valid for around 20 years, and the patent can be sold or licensed. That means if you're the patent holder, you can produce it yourselves, or you can decide to sell it to another company or to another body. That means that then the other person is then the patent holder and can produce the drug. The other possibility is to license a drug. That means that you're still the patent holder yourself, but you give another person or another institution the right to produce a drug. And that is mostly exclusive. So it means that only the licensee, that's how the person who holds the patent and is called, will then be able to produce the drug. Now, if another body decides to produce a drug, then that will have penalties and can lead to drastic fines. So that is then prohibited. So why do we patent drugs? So if you patent a drug, then you declare your own intellectual property. That means you have 20 years of market exclusivity in the EU. It is obviously monetary reward to recover investment, because if a drug company or a university conducts research into a certain drug, then this is obvious, then this leads to a lot of monetary investment. So you invest a lot of money into the research of the drug, the development of the drug, and also how it is then like packaged, for example, or marketed. And you want to get money back, to make a profit from that. And that is why you patent a drug, simply to make profit from it, and that incentivizes an innovation, because if other people would be able to develop, to sell the drug that you develop, then you might not want to develop new drugs. So while patents are really useful because they protect your intellectual property, they can also impair access to essential medicines. If you develop a drug and you're the only person or the only institution who can sell it, then this will lead to a monopoly over the drug. And that means that no other company can produce that drug, and you can set the price. And you can set the price as high as you want it to be, because you're the only person or the only institution that can sell it. And that can lead to impaired access to medicines, especially by countries who can't afford expensive drugs, or can't afford research and development into other expensive drugs. And that can be a huge problem, especially in countries of the global south. Now, I'm going to tell you about two very important amendments that have been made. The first is the Bail on Dole Act that was introduced in the United States in the 1980s. So in the 1970s and 1980s, before that act was introduced, patenting of publicly funded research was quite unusual. So normally when universities developed drugs, they didn't patent them. That meant that other institutions could then sell and produce and sell the same drug. So there was no monopoly over drugs, which consequently also means there were no high prices and drug monopolies. So after Bail and Dole Act was introduced, that promoted the patenting of drugs that were developed at universities. And because universities often don't have the financial resources to fund large trials that are necessary before you launch a drug onto the market, they sold the patents for those drugs to pharmaceutical companies or biotechnological companies, so that those companies who had the financial resources could then fund large trials and market the drug. And that is something called technology transfer. That is the process whereby you sell or you license a drug patent to another institution, for example, pharmaceutical companies. And then that led to increasing drug prices and decreased access to medicines in low and middle income countries. That was then followed by the TRIPS agreement in 1995. The TRIPS agreement stands for Trade-Related Intellectual Property Rights, and it is an agreement that was introduced by the World Trade Organization and signed by all its member states. And it so before the TRIPS agreement was introduced, developing countries did normally not allow product patenting in pharmaceuticals. That means when you were a pharmaceutical company, for example, situated in the United States, then you could not patent a drug that you've developed in certain countries, for example, countries that have a low medical infrastructure or quite poor, so can't really afford expensive drugs. That also meant that generic manufacturing by other companies was allowed, and those countries could afford medicines. But after the TRIPS agreement, drugs were also patented in middle and low and middle income countries, leading to drug monopolies and high prices, and thus also to less access to essential medicines in those countries. So some problems we have with patents are, for example, that when drug companies produce drugs, they don't think about the needs of developing countries a lot. Because if you produce drugs that are only sold in developing countries, you won't make a lot of benefit because you simply don't have the money to pay for it. So you will then be more inclined to focus on drugs needed in high income countries who can afford medicines, because they have working healthcare systems, they have working drug insurances, and so on. The second point is something called evergreening, that describes a process whereby drugs are patented, and then once the patent expires after 20 years, the drug is repatented because, for example, you change a bit in this the drug formula, and that gives you the right to patent the drug again. That means the patent runs for maybe 40 or 60 years, which then obviously where you still have the monopoly over the drug, and it will not be made accessible to marginalized populations. And that all culminated then in the AIDS epidemic in the early 2000s, between 2001 2003 in South Africa. As you might know, back then there were lots of very, very high rates of HIV in South Africa, but people could not afford antiretrovirals that are the drugs used to treat HIV, because the patents for those drugs were, for example, held by Pfizer, a pharmaceutical company in North America, and it was not just simply not affordable for people in South Africa, although it could have been treated. So one of those drugs called Stevidine, which is an antiretroviral, was back then invented or researched by Yale University. So they were the main patent holder over the patent for Stevidine. And they licensed that drug to a pharmaceutical company called Bristol Myers Squibb. And Bristol Myers Squibb held the monopoly over that drug because it was an exclusive licensing contract. And that also meant that it could set the price, and that was as high as $1,600 US per year per patient, the sum that could not have been brought up, that was not be able to be funded by the South African government. So what then happened is that Yale University, or students at Yale University, in cooperation with Médecins Sans Frontières, so Doctors Without Borders, another organization that stands up for equitable access to medicines, they tried to convince Bristol Myers Squibb that they allowed competitive licensing, so that they allowed generic licensing of that specific drug only in low and middle income countries such as South Africa. And that worked out. So Bristol Myers Squibb did not enforce the patent in South Africa and allowed other pharmaceutical companies, local companies, to produce that drug. And they could then produce a drug at cost. That means they sold the drugs for the price it costs them to produce it, and they didn't make a lot of profit from it, but that also allowed people to be able to afford it. And that was only $55 per year per patient. And if you compare that to $1,600, you see how large the profit margin must have been for Bristol Myers Squibb before it allowed generic manufacturing of the drug. So that success story continued, and there were lots of other pharmaceutical companies who also allowed generic manufacturing of HIV drugs. And that is also why nowadays people in South Africa and other African countries have access to HIV drugs, and a lot of lives could be saved. So that is just a film recommendation if you're interested in the AIDS epidemic and how access to antiretrovirals was provided. Then I can just recommend to watch this film. It is really interesting, and it's also really frustrating, but definitely can just recommend it. So just to give some other current examples of impaired access to medicines is, for example, insulin. Insulin is a drug that so many people use all over the world, people with diabetes type 1 and 2. And there are 4 pharmaceutical companies who hold patents over those drugs. And they have used something called Evergreening, which I explained earlier, to prolong the patent all over and all over again. And that means that a lot of people suffering from diabetes, even in North America, a developed country, cannot afford insulin and have to cut down on their insulin consumption, which can be fatal or at least increase morbidity. So also, as I already said, research is often not needs driven, it's often more driven by profit. For example, neglected tropical diseases such as malaria or, for example, the West Nile virus, they are only prevalent in countries around the equator, so in equatorian geographical areas. And in those countries that are situated there, they don't have a lot of money to pay for their drugs. So obviously the profit that would have been made from such a drug is not that high. And that is why research into those drugs is not really promoted there in Europe and North America. So that leads me to what we do at UAM, because we want to change that. So we have 3 areas of focus: innovation, access, and empowerment, which I will try to describe a bit more in detail. So the first thing is access. As I already outlined, patients in a lot of countries, not only low middle income countries, but also some countries in Europe, don't have access to certain medications, and that is what we want to change. The second point is innovation. As I said, a lot of drugs are not being researched simply because there wouldn't be a huge benefit from selling them. And that's also something we want to change. There's a lot of research into drugs against, for example, into chemotherapeutics or drugs against heart disease, against high blood pressure, because all those non-communicable diseases are prevalent in the countries of the global north. And that's the countries where companies make the most benefit of their profits. And that is why those drugs are developed. But drugs, neglected diseases, they are really unfortunately represented in development simply because the rich people in countries of the global north don't need them, and that is why they don't produce them. So that is just an example. As you can see, that is kind of a curve about the development of an antibiotic against a disease that is only prevalent in countries of the global south, so neglected disease. You can see here's a preclinical, the phase 1, phase 2, phase 3 trials. That is kind of the investment that pharmaceutical companies have to make before the drug is approved on the market. Then afterwards, they have the patent here, which you can see on the blue line. And then they have their peak year sales within the first 20 years when the patent is running. And after that, once generic competition is allowed, they will not make a lot of money by the drug anymore because other people will sell it for less money simply. And you can see it's not a lot of money they make by producing an antibiotic that is only sold in low and middle income countries and not used by a lot of people. As opposed to something called a blockbuster diabetic drug, which is used all over the Western world and in countries of the global north, here the income is so much bigger than the income from an antibiotic. And that is exactly why innovation is not prevalent in a lot of pharmaceutical companies, because there's no incentive, they're not incentivized to produce them. There's not a lot of profit. So We also want to empower students to change that, because we believe that students will be the future global health leaders. We want to educate students at universities because they will be the researchers and global health leaders in the next 20, 30 years. And if they know about these access issues, they might be able to change them on a policy level. This is our mission statement. I'm not going to go into that. If you're interested, I'm happy to outline it later, but it's just what we stand for. This is our organizational structure. So if you become a member, then you can vote in our different elections. And also we have our leadership body consists of an executive board, the European Coordinating Committee, which I am part of, and for example, the European Empowerment Committee. And we then also cooperate, not only in Europe, but we cooperate worldwide with North America. We have a lot of cooperation with Brazil, and we also try to expand our cooperation with other countries, which is why I am here today, because even within Europe, UAM is not prevalent in all countries. We do a lot of things. Just to give some examples, we organize a lot of campaigns, especially on campus, to get students involved. We try to talk to universities to change their licensing policies. We try to raise awareness by organizing speaker events, film screenings. We have the Access to Medicines Week once a year. And also we do a lot of international and national advocacy, work together with the WHO, with Médecins Sans Frontières. We have a lot of corporations, and it's quite interesting and quite intriguing. And I've only joined the ECC a few months ago, and there's still so much to discover, and it's really nice, and the people are so enthusiastic about everything. It's just so much fun to be in it, to be fair. So this is just some current projects I'm currently doing in the ECC, and also the ECC does. For example, what we do, we try to map public research funding. So we try to figure out where the funding from different countries in the European Union goes, if it goes to pharma companies, if it goes to universities, kind of map the research landscape to see if the public money we invest into research comes back to us. So if we, just how it's allocated. We try to cooperate with NGOs in science, for example, at the moment, to convince the European Commission of the EU to change some things about the current COVID-19 vaccine policy. That's something that will be later presented, I think, in the next presentation. And generally, at the moment, we fight for equal access to the new vaccine against COVID. We also try to do some facilitate policy changes. For example, our current framework is called ETAF. It's a bit complicated and it's a lot to get. I think it's a lot of input at the moment, but ETAF stands for Equitable Technology Access Framework. And it's a framework we try to bring to universities to make them change their licensing policies so that when they license a drug that has been developed at the university from public research, taxpayer money, that when they license that to a pharmaceutical company, that they include something called SRL policies, social responsible licensing policies, and that they make the drug as accessible as possible. And yeah, we also have a lot of resources, and if you're interested, I'm happy to talk more about that, but I think I'll skip that for now. And yeah, so if you're interested, to contact us, if you're interested to set up a chapter, because we work by having chapters at local universities, then don't hesitate to email us. And I'm also happy to give you my phone number, so you can always drop me a message on WhatsApp, and yeah, happy to get you involved, really. That's my sources. No one will look at them anyway, so just skip them. And there's a video, but I can't show it because it's a bit problematic with the access thing. So anyway, thank you, and I hope to see you join the movement.
Thank you, Lydia, for your very informative and interesting presentation. We all learned a lot. And now we can proceed with Kajal's presentation.
Great. Thank you so much. And thanks, Lydia, for actually setting up my presentation quite well. It's always good to hear about UAEM and what's happening in the universities with the students, because that is really where the change is going to come from. So it's great to hear about your initiatives on COVID. I'll just take a second to share my screen. Is that fine? Visible for everyone?
Yes. Yeah.
Yes. Okay, great. Um, okay, so firstly, thanks to the organizers for inviting me and for hosting this discussion. I think it's a really crucial one. It's sort of hard to believe that we've come towards the end of this year and we're still in the midst of many of these discussions and debates around who owns and controls medical technologies. I want to take off from where Lydia actually left off, and when she talked about the origin story for UAEM, where I think the last time there was so much global concentration on understanding the impact of intellectual property and patents on medicines was the AIDS crisis, when treatment was available but was simply not available in developing countries. And I think this year, 20 years later, we're seeing that same sort of laser focus come back on who owns and controls medicines, how they're made, who they're made for, and at what price they become available. But what's interesting about this moment or this year, 20 years later, and I wanted to sort of take you back to sort of the beginning of the pandemic, when the infections were just spreading. They started spreading mostly across Europe and the United States. And you started seeing a huge crisis in access to diagnostics and devices. So even before we got to the question of treatments and vaccines, you started seeing, a big shortage in masks, big problems in diagnostics, and with access to devices like ventilators. And suddenly this year has shown us that, it's not just the impact of patents on medicines or on vaccines, but we've seen how entrenched intellectual property actually is in all aspects of medical technology and how they've created barriers through this year. So what I just put on this slide for you all to have a look at is, for instance, you'll see on this side, is a snapshot that I've taken from a patent application or a patent for N95 masks. There's a company called 3M that globally supplies N95 masks. I mean, they're the most well-known company. They're also a big patent holder. They have hundreds of patents on these masks, and they're very aggressive in actually enforcing their patents on this. So you saw at the beginning of the year this very unusual call come out from one of the US state governors, I think it was of Kentucky, asking 3M to release their patents so that other companies could start manufacturing masks and that they would be more easily available. That, of course, did not happen. And from what I read last, even till now, 3M is not actually able to provide the kind of supply of N95 masks that are required globally, though fortunately, there are a few other companies that have stepped up. The next thing we started seeing that became very important in the pandemic was the question of diagnostic testing and RT-PCR tests, which are still the gold standard for testing for COVID. What I've got for you here is a snapshot of a machine which uses something called CB-NAT technology for diagnostic tests. This is a gene expert machine that's made by a company called Cepheid. Now, what's interesting about this machine is that it's actually used in most of our countries in the developing world for diagnosing multi-drug resistant tuberculosis. So these machines are actually installed in a number of countries in the South. So when Cepheid announced that they could actually use this machine to test for COVID-19, and the turnaround time for these test results is 45 minutes, that was really good news for most of us in the developing world, because you could suddenly have a quick test. They can't test that many samples that quickly, but whatever it is, there's a 45-minute turnaround. Except the way this machine works is that you have to buy cartridges. It's a bit like a printer where you buy the initial machine and then you have cartridge tests. Most of you who are medical students are probably quite familiar with this technology and this machine. And Cepheid unfortunately priced each cartridge for testing of COVID-19 at $20, when we know from groups like MSF and from Treatment Action Group that those cartridges with a profit could actually cost $5. So, and again, despite several calls on Cepheid to lower the price, to share the technology and let more and more companies start using this technology for diagnostics, that's not something that has not happened. The third thing that we saw was that happened in Italy was I think there were university researchers who started 3D printing of parts required for ventilators, because at the beginning of the pandemic there was this idea that the ventilators could help. We now know that should be beyond last resort because they can cause more damage. But at the time there were very few ventilators, and so they started 3D printing parts so that one ventilator could be used by 2 patients at a time. And immediately the company that had the patents on those parts of the ventilators, there was sort of noises being made in the media that they might actually sue these researchers for the 3D printing that they were doing. So again, we actually saw how patents, how other forms of intellectual property have actually seeped into all parts of medical technology and have created barriers throughout this year for improving access, not just to medicines and vaccines, but to all these devices and diagnostics as well. We then came to the situation of remdesivir. You finally had treatment that was announced. Of course, we now know from the WHO that it's not as effective, though it's still being used in many countries. Remdesivir was put on the market by a company called Gilead, which had initially come up with this drug for the treatment of Ebola. And once it was approved in the US and in Europe, you immediately had the US government purchasing 90% of whatever Gilead could produce, and the EU purchasing the remaining 10%. Now, Gilead is a company that most of us in the Access to Medicine movement are familiar with because they also make HIV treatment and they make hepatitis C treatment as well. And there have been ongoing battles with them on the pricing of these treatments. Gilead, I think, to avoid much of that criticism, quickly entered into voluntary licenses with companies in Egypt, Pakistan, and India, covering 127 countries where these drugs could be supplied to. Most of the companies that got those licenses were from my country, were from India. And what I've got for you on the left-hand side is you see that Gilead's price for a 5-day course of remdesivir was $2,340. And the minute you had multiple generic companies come into the picture, you see that price going further and further down till it's about $200 for a 5-day course. Yet what happened in India, with even 5 companies producing these medicines, was we saw a massive shortage. And we saw a black market actually emerge where people were selling these vials for 10 times or 20 times the cost. We had stories of patients' families driving hundreds of kilometers just to get one vial when you actually need 5 vials for treatment. And you might wonder that, you know, when we talk about generics coming in, you talk about more availability. What happened over here when you actually had this voluntary license come in? So what you see over here is actually research that was done by researchers such as Andrew Hill, who actually looked at the cost of treatment for drugs like remdesivir. And at that time, we were looking at lopinavir, ritonavir, and some other drugs, which of course we now know don't really work. But they found that actually with a 10% profit, the drugs for a 10-day course, remdesivir could have been sold for $10. But again, even though you see multiple generic companies, like I showed you on the previous slide, you don't see the cost or the price actually coming down to that. There are others who have said that $10 might be too low of an estimate. You should have a higher profit margin. Perhaps it could be $30 for a course of treatment. Fine. Even with that, we're nowhere near those prices yet. And these companies have now been in production for at least the last 3 or 4 months. So this is the sort of, to understand what's happening in India. This is a snapshot of the patents on some of the treatments that we're looking at for COVID-19. There's some promising news that has come in with this drug right on top, baricitinib, in combination with remdesivir. And then what I've shown you is the patents in India that have been granted on remdesivir. And what I would like you to see is the last column, which is sort of an example or a demonstration of what Lydia spoke about in terms of what evergreening is. Right, so you see over here that they've had multiple patent applications and patents that have been granted on remdesivir. Each of these is successive, so it actually elongates the amount of time that they have control over or a monopoly over this drug. And you see, and we'll probably see many more applications coming in for remdesivir. Similarly for tocilizumab, not used that much now in treatment, but it was initially, and this was actually should have been off patent in 2015 or 16. But again, you see in the last column, there are multiple applications that came in from the patent holder on this, and their control over this drug will increase. So what we see today, even with voluntary licenses and generic companies, is a very different situation from what we saw with HIV in the beginning, which Lydia was referring to, where the prices of treatment came down so drastically. We have now what some of us call managed competition. So if you'd had an open space, if you'd had multiple generic companies, and India has multiple generic companies actually producing remdesivir, you would have probably seen a much more drastic fall in prices, and you would have seen much better availability. As it stands, the Indian companies that have got the licenses are barely producing enough for India. So I don't even know where the question of export comes in. And I think that is going to be a question for us with other COVID-19 treatments, as well as vaccines, as we're starting to see now. With patents on vaccines, we're starting to understand actually the impact and the depth to which patents actually impact vaccines. There is a very commonly held belief, or a very traditional belief, that actually patents and intellectual property is not something that impacts vaccine availability or affordability. It's other issues, you know, related to how small the market is, how low the prices of vaccines tend to be. But over the last 10 years, there are multiple groups and medical groups like MSF who have been trying to access vaccines for their medical projects. And they put out this very interesting report a few years ago, trying to understand actually the extent to which intellectual property plays a role in vaccines. And what they discovered was this snapshot of the version of evergreening that Lydia spoke about that happens in patents on vaccines, where you see patents on starting materials, on the DNA sequence, the expression factors, the host cells, on the composition, on the process technologies, which includes filtration and purification, and then even for the methods of using it, which includes dose forms and the ages in which vaccines can be used. So what we discover actually when you look at the the patent landscape for multiple vaccines is actually you see a huge, what we call thicket of patents that exist on these vaccines. And there's a very interesting report that talks about the hepatitis B vaccine, which is used by people who normally say, look, vaccines and patents, it's really not an issue because the hepatitis B vaccines came out, there were 2 producers, the prices went down. But what most people don't know is that they needed nearly 90 licenses from different universities and other bodies before they could actually produce those vaccines. What can we see happening in the case of COVID? In the case of COVID-19 vaccines, we won't know till the middle of next year, actually, the kind of patents that have been filed on it, because that's how patent filing works. Patents that have been filed or applications have been filed this year, we will find out and they will be published only next year. But there's been a lot of research that has happened on coronaviruses in any case, primarily because of the previous SARS-CoV outbreak. And the European Patent Office has this useful resource that shows the coronavirus patent applications, vaccine patent applications. And you can already see from this map that there are thousands of patents and patent applications just on the current state of coronavirus vaccine patent research. So for anyone who's looking to produce and to manufacture, they will be thinking about whether they will be infringing any of these patents and whether they're looking, they could potentially get sued. And that in itself creates a barrier. Just to give an example of, I think, the work that UAEM does in really trying to promote, because we know basic research really happens in universities. And I think one of the unfortunate examples that has come out of COVID-19 is the Oxford vaccine, which is now known as the AstraZeneca vaccine. And initially, Oxford had put up on the left-hand side, you can see a really good policy where they had said that any research that they do on COVID-19, they will ensure that there's non-exclusive licensing for anyone who wants the technology from them. That very shortly turned into an exclusive deal with AstraZeneca, where they transferred the rights to AstraZeneca, who now owns and controls how the Oxford vaccine, or now the AstraZeneca vaccine, is going to be produced and where it's going to be available. So this has been a slightly unfortunate outcome for this year, where we would have wanted university research to be widely available, where immediately it went into the hands of exclusively of just one private partner. And what we're discovering is that it's not just patents, but something called trade secrets. You may have heard of this more in the context of it's usually referred to as confidential information or proprietary information. I think the most famous example of this is the recipe for Coca-Cola. You know, the Coca-Cola recipe is famously secret, and so therefore no other company can make it taste the same or whatever. But these trade secrets actually play a huge role in medical technology as well. And what we're seeing for vaccines particularly is that these trade secrets could cover the cell lines, the genomic information, other biological material that could be held as trade secrets. But data about the effectiveness of medicines and vaccines are also considered trade secrets, and even negative information about what does not work can be a trade secret. And what we're starting to see is that it's not just patents on medicines or on vaccines, but these trade secrets that are allowing companies to actually fence the technology. And if they're not willing to transfer that technology, it's not openly available, and would take much longer for other companies or other competitors to actually start producing any of these vaccines or medicines. I'd encourage you to read this excellent paper, this work being done by this Professor David Levine, who's really been following this and keeping many of us up to date on how to understand the impact that trade secrets have. But what we've seen in our countries is also that it's not just an impact on access. Many of us who've been working in developing countries, and we're seeing a lot of emergency applications for treatment, for vaccines coming in. We're looking for clinical trial data to be put out in the public domain. And we've actually had a couple of our drug regulators come out and say, we're worried about putting so much of this data out in the public domain and being transparent, because we could be sued by the companies that we've taken their trade secrets and put them in the public domain. And this is a really worrying concern, because I think transparency, especially when there's, what's been called warp speed development happening of medicines and vaccines, you want this data to be publicly available and subject to as much public scrutiny as possible. So but it's sort of this intellectual property fencing that's happening is having many diverse effects is what we're sort of starting to see. If you've seen
Sorry.
WHO's COVID-19, sorry?
No, sorry, Kajal, I'm sorry to interrupt you.
Yeah.
But if you could have another 2 minutes or so, and then just,
All right, fine.
yeah,
Okay.
thanks.
Yeah, okay, fine. I probably need about 3-4 minutes if that's okay. Yeah, I'll just get to.
I think we'll live. Yeah.
Yeah. I think actually some of this will probably be covered a little bit in the next presentation as well. So I'm going to skip these slides, but I think what we're really seeing is a lot of shortages that are happening in the vaccines. As Lydia already mentioned, you're seeing that most of the developed world has actually bought up most of the vaccine doses that are available. And there's a lot of talk about inevitable shortages. But I'd encourage you to go to this other website called vaxmap.org that's been maintained by the Third World Network. And you actually see that there's a lot of vaccine production capacity outside of the United States and Europe. So in fact, if the technology was shared, you could have a lot more vaccine production and availability happening, but we're not seeing that at the moment. The international initiatives that we've seen at the moment are unfortunately really focused on voluntary mechanisms. There's something called the COVAX facility where just, I think this week, there's reports in The Guardian and other media talking about how there's a high risk that this facility is going to fail because not only have they not managed to get the money that's required to buy doses for developing countries, they have not even got commitments from companies for the amount of doses that are going to be required just in the next 6 months to a year. The other sort of initiative is this COVID-19 technology access pool, which is the idea of pooling the technology related to treatments and vaccines and any other technologies for COVID-19. But unfortunately, there's not a single company that has expressed any in this. And countries out of their scope. And we're also potentially looking at an impending health crisis, even for things like TB and HIV, where we know those responses have gone off track. And again, treatments for these diseases are patented. So whether our developing countries are going to be able to pay patented prices, forget for COVID-19 treatments and vaccines, but in the coming year, when the economic crisis really hits us and we understand the impact on our budgets, we're not going to be able to pay for patented drugs for these treatments as well. So I don't want to end on a negative note. I wanted to highlight some of the excellent work that's happening from community groups around the world to take on the system that is leaving us in this place. And I wanted to start with a quote from Amit Sen Gupta from the People's Health Movement, who unfortunately left us 2 years ago. But for those of us who he taught, he would always tell us that optimism, you must treat optimism as a purposeful act of political resistance. That even though we see this entrenched system and we've seen 9 months of trying to get over the system, we have to be optimistic of where we can go. And that optimism actually comes from the AIDS pandemic, where we saw in 2001, there were a high number of deaths in sub-Saharan Africa, even though treatment was available, to today where we have over 30 million people who are on treatment. And Lydia already showed you this graph of the dramatic drop in prices of treatment, where we know it can happen and we know that there is the capacity for production. So what's happening with COVID-19? We've seen a lot of countries actually taking steps. Israel has issued a compulsory license for lopinavir, ritonavir. Multiple countries have changed their laws so they can issue compulsory licenses for COVID-19. But what's really interesting is what civil society groups are doing across the world, such as in countries like India and in Argentina, where they're filing patent oppositions and challenging the patents that have come on remdesivir and plan to do the same for other treatments and for vaccines, so that they can open up the pathway for generic production. South Africa and India have gone to the WTO TRIPS Council with a proposal saying that for the COVID-19 pandemic, we would like a waiver of enforcing any intellectual property on these technologies, because that is the only way that these treatments and vaccines are going to be available in the South. That, of course, has been met with a lot of resistance from developed countries, and it would be great for people on this call and for students and universities to take up this mantle of challenging the EU and the US in their resistance to this. And what the South Africans are now calling vaccine apartheid that is emerging, because you have the North buying up all the doses, but refusing to open up the technology to the South so that the South can produce these vaccines for themselves. We've seen enormous mobilization around this that has happened. Avaz sent to the WTO over 900,000 signatures from people across the world supporting the waiver. And what was very interesting about this, on the right-hand side, what I've given to you is a snapshot from the WTO website, acknowledging that they've received this petition. This is extremely unusual, and it shows the amount of pressure that the WTO Secretariat is feeling from public action and public mobilization. So anyone who feels that sometimes you feel that you don't see your actions resulting in things very quickly, this is a huge step forward for the WTO to acknowledge that they've got a global petition asking for the waiver. So I'm just going to end with this famous quote from Jonas Salk, who was the inventor of the polio virus vaccine, who, when he was asked, who owns the patent on the polio virus vaccine, he said, the people, I would say, that there is no patent, and could you patent the sun? And I think that is exactly where the challenge to the system that we're looking at is going to come from. It has been in the last 20 years, people fighting against, patents on cancer genes, on cancer medicines, on hepatitis C medicines, on HIV medicines, pushing back against trade agreements that actually try and increase the power of corporates over our treatments. And that is really why I'm so excited about this discussion and this conversation we're having today, because that power is going to come from communities. It's going to come from university students and from the medical profession that I understand that many of you belong to. I really like this slide, so I show it often. That when you look at the problem, it's not that the deer is crossing, the deer is not crossing the road is crossing the forest. This is not just a question that many, including people like Bill Gates, think is a question of throwing money at the problem. There is a systemic problem that we need to acknowledge now and that we need to challenge. I'll end with one last quote from Amit, and then I'll wrap up, where he said that the struggle for health is a struggle for a more caring world. And I think that we are here to build a more caring world. And if we don't get a more caring world out of the COVID-19 pandemic, then I think we're probably lost as humanity. And I'll end over here. Thanks so much.
Thank you, Kajal, for your presentation. It was great. And now, third presentation will be held by Julie.
Good afternoon, everyone. So we'll start screen sharing so you can follow the presentation. And I'm also dropping the link to the campaign that I will be talking about in the chat. So already many thanks for the organization of this webinar. And the presentations we had beforehand, really great informative information on like what are patents, what are the problems with these, and also many thanks to Kajal to explaining exactly why a popular mobilization is needed right now, because we all fear that we are stuck in the situation of being in a pandemic and not being able to share a solution to it with everyone in the world, but that's exactly what we're trying to do. With the European Citizens Initiative, Right to Cure, that has been set up. We need to mobilize or gather the much as possible support to make sure that future developed vaccines, treatments, and technologies against COVID-19 will be in public hands and will be universally available for everybody. So that's why we started a European Citizens Initiative. Called Right to Cure, No Profit on Pandemic, which would be in Croatian. No, I'm not going to try that. I'll leave that for the outro. So what is a European Citizens Initiative? European Citizens Initiative is actually a way for citizens, so society organizations, to have a direct influence or impact on the European Commission decision making. It's a way to introduce legislative proposals directly to the Commission. It kind of puts citizens at the same level as elected European parliamentarians, which is quite amazing. And it's also a really perfect way to show popular support existing for specific subjects as this one. Of course, you can't just ask the Commission to discuss any proposal you want. For them to do so, we need to collect 1 million signatures in all European member states in total. So this is the challenge we face now. We started a European Citizens Initiative exactly with the demand that we want the European Commission to put everything in place to make sure that vaccines, treatments, and technologies are universally available, affordable, and in public hands for everyone. We started this initiative some 2 weeks ago, 30th of November. We are close to collecting 15,000 signatures by now. And we established a coalition of over 90 civil society organizations, of which UAM is part, and also Anna's and Carla's organization, and a whole bunch of very interesting student organizations and trade unions in Croatia. So our strategy to get out of this pandemic is exactly popular mobilization. Kajal already introduced it and showed the parallels with the HIV pandemic really good. It was mostly in the 90s, in the beginning, early 2000s, that in South Africa, a big movement started to demand that HIV treatments were affordable, patent-free, accessible for everybody. And eventually they won. But it's very important to point out that firstly, this was not just because the politicians were intelligent enough to do so. It was because popular mobilization put pressure on governments, on companies, on international institutions for years, for decades, to make sure it happened. But it took time. It took over 10 years for the companies to give out their patents, to stop intellectual property rights, to make the treatment available for all. So we don't even want to imagine how our world will look like if we would have to wait 10 years to be available for all. We simply do not have this time. We didn't have it with the HIV pandemic, and we don't want to be in this situation again. So questions are now being raised, and we're applauding very much, and rightfully so, the great work done by scientists to develop in this short time a vaccine. But it's also important to point out, as has been said in the previous presentations, that there's also a bit a glitch or a problematic in the current for-profit development model that we are based on. Because actually there was already lots of signs, alarm bells going off years ago that we might end up in the situation that a coronavirus, of which COVID-19 is a specific one, would come up at a certain point and would be super infectious and would spread all over the world and end up in a pandemic. So call was made by scientists, by public health experts, even by the European Commission to develop a vaccine to be prepared if in case this would happen. The Commission even put available a certain budget to develop this vaccine, but no pharmaceutical companies were interested to take on this research because they weren't sure that a pandemic would happen and that they would get any profits out of it. So we could have avoided the whole situation we are in right now if we would have stepped up of this profit-based development model of pharmaceuticals. But now we are, of course, in a different situation. It is quite interesting for private pharmaceutical companies to invest in the development of a vaccine because their market is basically the whole world, and governments are quite keen on paying lots of money to have a vaccine for their population so they could get their societies back going. So the graphs that I'm showing you now are, I think, were published last week and sparked lots of discussion, but because it shows, or it gives kind of a counter argument to the claim that the pharmaceutical companies have been putting lots of money in the development of these vaccines, and this would rightfully be allowed to ask a high price for it. This is not the case. Because we would need a vaccine this quick, public institutions, governments like the European Commission actually funded for the biggest part the development of these vaccines. For example, we have the Pfizer biotech. I think this is a vaccine that is mostly being negotiated or bought right now, was for over 2/3 funded with public money. The Moderna one was by a large part, you can see the blue boxes, was funded with public funding coming from the US government. Same for Oxford AstraZeneca. These were not for profit or public funding, public taxpayers' money, our money to say so, that was used to develop the vaccine. These were funds that were collected nationwide, sometimes by specific governments like the German one, sometimes by the European Commission, to encourage pharmaceutical companies to focus on the development of a vaccine. So basically, we paid for it. We already paid for it. So it's a bit strange that we are right now discussing how much we should pay again to have access to these vaccines. Because we see on the other side of the graph, there's also like a very big difference between the prices asked per dose for a vaccine by the different companies. It goes from, say, 4 per doses for the Oxford AstraZeneca as the lowest price to up to 37 per doses, which you might say, yeah, you know, it's a reasonable price. I would be happy to pay 30 euros, even 40, you know, to be able to get my life back. But we also have to ask the question, like, maybe for us, it's affordable, but is it also justified? I think in Croatia, but also in Belgium, the government already said, like, patients will not have to pay for the vaccine, which is, I think, one of the biggest demands that we have. But in the end, it's your social security system that will have to pay for everything. It will be lots of public funds needed to pay health workers, to make hospitals, to basically take care of the health system, that we are now actually giving to private profiteering budgets or shareholders' interests. So it's really problematic that we, from one side, do not know how much money was put in the vaccines or how much public money was used from one side. And on the other hand, that we have no clue what are actually the production costs of those Pfizer, AstraZeneca, Moderna vaccines. Basically, because pharmaceutical companies can put any price that they want on the vaccine, thanks to the patent, the intellectual property rights that they have, they can say whatever they want and they can charge whatever they want, which is quite absurd when we know that actually it was us that funded the development of these vaccines. About giving a bit of respect or being grateful for the scientists or pharmaceutical companies behind these vaccines, because here's another news that was published yesterday that Pfizer already knows that will make billions of profits by selling these COVID-19 vaccines. And just to really grasp, profit is the extras. It's not about paying the production, paying for the distribution. It's not about paying their workers. This is really just billions of money going to shareholders and not to public health systems. So it's definitely not justified that we should pay this much. And in the beginning of the pandemic, it was actually it looked good. We had the left picture is President of the European Commission, Ursula von der Leyen, who stated herself that the future vaccine will be a universal common good. So we thought, okay, this is going well. We are in different age. It's like the year of global solidarity. We'll stop intellectual property rights, have vaccines for everyone. But no, we can see on the right that we are still doing business as usual. And indeed, as already was pointed out, that as things stand now, only rich countries will have access to the coronavirus vaccine in the coming years, and poorer countries, or even over 90% of the population in low-income countries, will not have access to a vaccine maybe in 2023. And as we know, this is just even beyond the ethics or the humanity of this. It's also problematic because as long as people are not protected, no one in the whole world will be safe from the coronavirus. So brings us back to what can we do as a citizen, which makes me happy to be able to present this campaign. European Citizens Initiative is adding this public voice to the concern already expressed by NGOs, networks, public health experts, Nobel Prize winners, that we need to do things differently this time. To be able to have a vaccine as quickly as possible, as accessible as possible, as affordable as possible, we need to drop intellectual property rights. So that's what we are claiming. We want to get the support. We need to get support of at least 1 million European citizens to make sure the European Commission takes up its responsibility and assures that any vaccine that was sponsored with public money must commit to full transparency on its production costs, on the clinical data as well, the safety of the vaccine, the effectiveness, and also about the negotiations going on and the price that we are exactly paying. We want health for all, we want transparency now, we want full public control over what is happening with the vaccine, who is getting it, and we are demanding that in a pandemic, profiteering shouldn't be allowed. So that's why I'm calling you to please go to www.noprofitonpandemic.eu and sign the European Citizens Initiative. This will be a great effort and will have a great impact. Sign it yourself, share it with your family and friends, send WhatsApp, Messenger, Facebook messages, emails. It's really the best way to get, especially during, but make sure to talk about it, make sure to raise the issue of public control, the pricing, and the global access, and to help us get those signatures the fastest way as possible so we can really put the European Commission to its responsibility. I'll close here so we can have a,
Thank you, Julie, for another great presentation. As I said, we can now move on to discussion. So I want to just say once again that you can still type your question in the chat box or use the raise hand option if you want to ask question by yourself. So the first question is for all speakers. What would you say are some of the most impactful positive wins of the Access to Medicine movement? You already mentioned the struggle for HIV drugs in South Africa. Are there similar experiences in other places?
Actually, yes. There have been other pharmaceutical companies, for example, Gilead Sciences. I think it's a pharmaceutical company based in the United States as well, and they have agreed to make a antifungal agent called amphotericin B available to low and middle income countries for those for treatment in something called Leishmania. I don't know how it's pronounced. Only know the German word for it. Something called Leishmania or something like that. It's a neglected tropical disease, and so that's been a big success too. So there are individual successes, but it's not. I think what is missing is more like a broader structure or a broader support for this movement, more legislative action. Because right now, what is happening is that we rely on pharmaceutical companies to make those decisions, rely on them to concede to make their patents available to other manufacturers as well. But we don't have any governments that would make it imperative for them to share patents, and that I think is a big problem.
Thank you, Lydia. Kajal?
Yeah, maybe I can highlight a few examples of where civil society groups, community groups particularly have challenged quite successfully patents on key medicines. I think this is something that has really developed in the last 10 years. Before this, the only conversation used to be about compulsory licenses to be issued on patents on medicines. And we did see a lot of countries actually doing that for HIV medicines. And then eventually Thailand started issuing them for cancer treatment, for other diseases as well. But one of the interesting things that has happened in the last 10 years is that this idea that the patents that are granted are legitimate is being questioned. And I think that is a very interesting thing of challenging the foundation of the system, because very often the only conversation we have about is of access. Now there's a conversation about innovation, but there's a big question on these patents themselves that are being granted, whether they are legitimate whether they should be granted to these companies to give them these extended monopolies or not. So we have seen organizations and groups starting from Thailand, India, Argentina, Brazil, and now actually across Latin America, across even organizations in Europe, starting to file oppositions to patents on key medicines and actually winning those. And when those actions are successful, they allow local producers or local manufacturers to make those medicines. And we've seen huge price drops as a result of that. So there's actually now a question of the legitimacy of the system itself, of the patent system, not just in terms of the impact on access, but whether the patent system is actually granting or recognizing true innovation and inventions, or whether it's this evergreening minor tweaks that are allowing companies to have more control over our medicines. The second example I might give is of South Africa, where the organizations over there for the last 10 years have run a campaign for reforming their patent law to ensure that there's as many health safeguards in it as possible. And it's been an uphill battle for them. And today you see South Africa really leading the global charge at the WTO along with India, asking for this waiver of intellectual property protections on COVID-19. And as I think Lydia and Julie both said, all of these actions that you see, when you see governments stepping forward, they're actually based on mass mobilization and community actions that push the governments towards taking these actions. And that's, I think, the most crucial thing to remember in that.
Thank you. We have another question for all speakers. Do you know of any successful examples of organizing for accesses to medicines in Southeast Europe? Kajal, you can.
Sorry, Southeast Europe, I'm sorry, could you mention what countries you'd be talking about?
The question is, I mean, it just says in Southeast Europe. So any successful examples of organizing for accesses to medicines? It's for all speakers, Julie, Lydia, Kajal, whoever wants.
Sorry, yeah, I think that would refer to Macedonia, North Macedonia, Serbia, Slovenia, Croatia. So basically, yeah, maybe also expand to Romania and Bulgaria, but yeah, pretty much the location.
Okay, I'm not that familiar with specific local movements in any of those countries, but I do know that a few years ago, when there was particularly a crisis that was happening, and I know that this doesn't actually cover any of those specific countries, but we have seen in Greece, for instance, when there was a concern rising around particularly, austerity measures and the impact that was having on health systems, you did see a sort of burgeoning movement and a challenge coming to why the prices of medicines were so expensive, why companies were charging so much and burdening the health system. And I think at one point there was even a conversation amongst activists in Greece about issuing compulsory licenses for some of these high-cost medicines. I don't know if you remember, this was 4 or 5 years ago, where there was a crisis, not just in Greece, but in several countries where the health systems were getting burdened by the prices of medicines. And you did sort of see these campaigns coming from, questioning from the ground by treatment activists, questioning why the prices were so high. But specific to Croatia, Slovenia, I might have to do some research to check on that. I don't know if Lydia or Julie might be more aware of local campaigns.
I have to admit myself that as I'm quite new to this movement, and also because UAM is mostly active in Western and Central Europe, I'm not aware of any movements. There are some movements, probably more local movements, but I would have to do some research. I could certainly come back to you with that, but I'm not aware. Maybe that's also because not as much research is conducted at universities in Southeastern Europe as it is in Central and Western Europe. That might be a reason, but I cannot really answer that question. I'm really sorry.
Thank you. Thank you. We have another question for Kajal. What would you say is the real use of COVAX? From your perspective, is this the right approach for achieving more equitable accesses?
So the question is specific to the COVAX facility for vaccines, right?
Yes.
Okay. That's a big question, and that's probably a whole separate webinar where you need experts looking at it. But The main idea behind the COVAX facility is sort of this development that's happened over the last 10 years, where there's been a lot of focus on voluntary mechanisms to encourage companies to provide access. And we started seeing the limitations of that. COVAX essentially is a facility to provide what's called advanced market commitment. And the idea is that if you can in advance tell the companies that you're buying X number of doses, then you can convince them to make a commitment at a lower price. Now, this may have worked to some extent, and even though there's criticisms of it, this has actually been promoted by organizations like Gavi and CEPI, and there is a lot of critique of that from groups like MSF of what they've done with previous vaccines. In the case of COVID-19, it's very difficult to think of an advanced market commitment as an incentive for companies to provide these doses when there are secret bilateral deals with developed countries throwing as much money as they're asking for. So a COVAX facility, which is trying to provide for 92 countries at lower prices, then is automatically much lower down the order in that. So I'm not sure an advanced market commitment actually works as a mechanism to encourage companies when they have limited production capacity. The doses that they're producing have already been bought up. And there's absolutely no real pressure from the international mechanisms for them to open up and share their technology. So I think in theory, the idea of COVAX was, to pool the demand, to pool money to help developing countries to actually pay for those vaccine doses, because many developing countries will not be able to. But I think if you saw that map that Julie had put up showing who's going to get the vaccines and when, that was put out by The Economist, I think that really shows you the flaws in the system of trying to rely on voluntary mechanisms to get the companies to do the right thing. Today there's news in The Guardian that Vietnam has a local vaccine candidate that they have started trials on. And I think that's what most countries are ending up doing, is looking at local indigenous vaccines. They may come 6 months down the line, but I think it's a bit of a tragic statement that countries by their actions are showing that they don't believe that global solidarity is actually going to help developing countries, that developing countries are on their own. They better come up with their own vaccine candidates, even if they come 6 to 8 months later. Because relying on what's out there right now doesn't seem to be working or functioning. I don't know if Julie or Lydia have a more optimistic view of COVAX and what it could deliver, but I myself am quite cynical about the facility and their ability to pressure companies into doing the right thing.
Yeah, I think this week, if I can add, the European Commission said that they would grant 500 million to the COVAX facility, 100 direct donation and 400 would be loans. But there's still lots of questions around the origin of these funds, because it seems like there's some 500 million extra money coming, but mostly these are already development aid budgets, sometimes philanthropical contribution that were already budgeted somewhere. So it's still money needed for development issues, public health systems paying the same prices that pharmaceutical companies are charging us. So it's not necessarily a fair solution. It's still a charity issue and not a structural solution to the situation we have right now.
Thank you. We have another question for Julie. Some countries in Europe have already announced they would make COVID-19 free at point of accesses. Does that influence the campaign, and how?
Well, it definitely it gave positive vibes to the campaign, because it showed that our first demand that the vaccine should be available for all for free was already accepted by lots of governments, showing that they are listening to what we're saying, which is always nice to know. But it also made us shift the communication or the debate that we had to do. Now the issue is not individual access for European citizens, but it's more to inform the citizens that we are paying, even if we don't have to put money on the counter when we go to the doctor or the pharmacist. We are still contributing to these vaccines with our taxes, social security systems, etc. So it's a good thing that it's free of charge at the point of delivery, but it's also a bit confusing or difficult to believe that it's actually free. Nothing is for free.
Thank you. Another question, Julie, for you. Which countries do you expect to be involved by the EU from European Commission after you collect 1 million signatures?
Involved in what way?
I only have the question, but
You mean campaign-wise, or like MEP?
I think that the question was by campaigns.
Well, now in our European coalition, we have established national committees in Belgium, France, Spain, Croatia, of course, Netherlands. I'm not sure if I mentioned Italy already, Spain, which is good, but we have to expand to other countries as well. We also need to collect signatures in at least 7 European member states. So we are really trying to reach out to other member states as well. I hope if people are here from Germany, Greece, Romania, Bulgaria, very welcome to contact me, and we can see how we can work together on that part. But we're happy to have France and Germany already involved in some kind of way, because these are also the countries where the pharmaceutical companies are based mainly.
Thank you. Thank you. Now we have a question for all speakers. In order to distribute vaccines or other medicines around the world, you need to have functional supply chain. Moreover, COVID-19 vaccines requires -70 storage temperature, which is very hard task to accomplish. But problem is that almost all of supply chains, especially shipping lines, are in private hands. Are there any available legal mechanisms which we can use to pressure governments to take control of supply chains and ensure quick distribution of vaccines?
So I'm going to take a shot at that question, but it's difficult to answer specifically because each country would have different sort of legal mechanisms. But I think there's a few different ways to look at that question. One is, I think, something that Lydia had brought up in terms of what kind of innovation actually happens. That for a vaccine that has to be widespread or should be available across the world, that the technology requires -70 storage, which is unfeasible. I don't think most developing countries are actually looking at this vaccine simply because that kind of storage is not going to be available, and it's going to be difficult to sort of maintain. I think the second question is, why should there be supply required from very small sources of manufacture, where you could have diffuse sources of manufacture and you may not have such a big supply chain problem. But yes, -70 is almost, it's extremely difficult to achieve. I know that Pfizer has applied for approval in India, and what they're proposing to the Indian government is that they will take care of the cold chain. They've got storage bins that they will supply through their shipping containers, and briefcases that are being particularly done. But you can imagine that this will apply to a very few number of doses, and I think it's going to be only for the elite in India if this sort of even comes in. But in terms of legal mechanisms to take over supply chains, I think many countries do have laws that are based and are being used. I think in the US, for instance, they're talking about defense laws or national security laws. There are ways in which governments can take these over. But if they're particularly fragmented, it may be difficult. And I think that brings up the question of having a vaccine that's more adapted to developing country situations, or even for developed country situations where they can be stored and supplied more easily. I think those vaccines are probably coming down the line. I think the second, third generation of COVID-19 vaccines are going to have easier storage. Some are even looking at a warm vaccine for developing countries, and those that are more sort of stable. I know that doesn't really answer that, but just wanted to highlight some of the issues that question brings up.
Thank you. We have a question for Julie. There were proposals made 15 years ago by people like Jamie Love to separate R&D from production of medicines, where R&D would be eligible for grants by public hand funders, but the production would be then awarded to generic producers. The COVID-19 vaccine was almost a perfect opportunity to test that system. What was your opinion of that proposal?
I think it makes perfect sense. And the crisis we are in right now is an example why the solely trusting or having this private poll based on market principles isn't working, and definitely not during a pandemic. Since we were unreasonably overwhelmed by the situation, I don't think testing this system would have been possible right now, but it definitely should be an alarm bell to start testing this or setting up a public poll of research and development and producing medicines as one of the priorities for global institutions.
Could I just add a point to that? I think there's been a discussion at the global level for a research and development and R&D treaty for almost a decade now. And that's precisely based on the idea that firstly, priorities for research should be set in public interest and not in private, so that you don't end up with vaccines that are impossible to store and to supply. And then, of course, you have this model where you have upfront granting. Now, if you look at what's happened with most of the vaccines and the slide that Julie showed, that's sort of actually what's happened, is that governments have given vast amounts of money for the development of vaccines, for the clinical trials to happen, for supporting their manufacturing. There is talk today that the Pfizer vaccine, they're having problems in getting raw materials. So the United States might use its Defense Production Act to help in speeding up getting those raw materials. So in fact, you actually see the first part of that proposal where governments are putting upfront public money into development actually happening in the course of COVID-19 treatments and vaccines. But the second part of that, where that technology then should be open and licensed non-exclusively, that we seem to have completely messed up on that part of the bargain. So the governments are paying upfront, as both Julie and Lydia pointed out, and then they're sort of also paying double or triple later with what's coming out, and without any conversation about the technology being opened up. I think there'll probably be quite an interesting legal battle that's going to happen on the Moderna vaccine, because the technology for that, the funding for that, the clinical trials for that, there's been huge US government investment. And I think organizations like Public Citizen and KEI are really following that closely and continuously highlighting the fact that actually it's the US government that owns that vaccine, and so the technology should be opened up. So let's see where that very interesting battle takes us.
Thank you. And we have one last question. It's for Julie. But my question was actually about vaccine distribution. It was the question we asked before. Here we are speaking about lower income countries such as Bosnia or Serbia, which are not in the EU. To which countries do you expect EU Commission to distribute vaccines with your 1 million signatures?
Yeah, I lost you for a moment. It's a good question. Universal access, so we're not pointing out countries specifically because the claim would be for everyone to have easier access to these. And it's one of the problems that we point out, that even if richer global institutions like the European Commission or countries are funding the research, it shouldn't be a justified claim that only they would have prior access or only access to those pharmaceutical products. Also yesterday, there was a parliamentary debate with the European Commission on the vaccine strategies. And there the commissioner already in very general terms stated that they would support and fund the distribution of vaccines in both lower income countries, but also in the Eastern European region. He wasn't quite specific on it. He was also not very specific on in what exactly way he would stop the intellectual property rights and support the WTO waiver. But there are definitely happening things on that side, but it really needs closer follow-up from campaigns like ours and civil society organizations to make sure that they actually really help in spreading the vaccine in non-EU member countries as well.
Thank you, Julie. Thank you for all your questions. And thank you, Lydia, Kajal, and Julie, for the great answers. Before ending, we would like to highlight once more that Lydia spoke about terminology and problems caused by today's models of research, development, and production of vaccines and other medical products. Thanks to her intervention, we know more about the general context influencing people accesses to health technologies, both COVID-19 related and others, as well as the main drivers of the global accesses medicine movement. We also heard about efforts to involve students in the movement, as well as a strong campaigning going on continuously. And a reminder that you can learn more about UAM by visiting their social media webpage, which I will now copy in the chat. And you can go and search. So this is the webpage. Further, Kajal informed us about the international framework, respectively how current trade relations and intellectual property regulation can restrict access to medicines and other medical devices. Now, we have expanded knowledge about the proposal for temporary suspension of intellectual property rights submitted to the World Trade Organization from the World Federation of Public Health Association. The proposal seeks to resolve the restrictions by lower middle and higher middle income countries, as defined by the World Bank, to have timely, affordable accesses under competitive market conditions to COVID-19 diagnosis kits, medical devices, and particularly vaccines and medicines to combat the virus. A pandemic cannot be resolved in a small number of countries. Kajal let us know that one of the main reasons this open letter was written in the fact is the general fact that 80% of the doses that could be produced during 2021 have already been committed for high-income countries, which make up 20% of the global population. We would also like to point out Julie's powerful words once more, and those are, we all have a right to health. In a pandemic, research and technologies should be shared broadly, fast, across the globe. A private company shouldn't have the power to decide who has access to treatment or vaccines and at what price. Data on product costs, public contribution, and the effectiveness and safety of vaccines and medicines should be public. We cannot allow big pharmaceutical companies to privatize crucial health technologies that have been developed with public resources. Therefore, health for all, transparency now, public money, public control, and no profit, no pandemic are demands of European Citizen Initiative, and you can sign the initiative on their official page, which I will copy in the chat. And the page is noprofitnopandemic.eu. Thank you all for participating. Lydia, Kanjal, Julie, I want to thank you once again for a very informative and interesting presentation. Thank you for taking your time and passing on so much knowledge to us.
Thank you so much for inviting us. This was great, and it's actually a nice way to end the year, to think about community mobilization for next year, because I think we're really going to need our strength to do this. So I think this was really timely to do. I had said that maybe if people could put on their videos, it would be nice to see everyone rather than the black brick walls that we constantly look at. So whoever can put on their videos, it would be nice to see you. And yeah, let's look forward to a revolutionary new year.
Couldn't agree more.
Also, I want to say thank you for having the opportunity of speaking here. It's been great, and I hope to see some of you at UAM in the near future. And I wish you all a good Christmas and already Happy New Year. May it be better than.
Definitely. Thank you.
Thank you very much.
Everyone.
Thanks to everyone.
Thank you very much.
Thank you. Nice to see you all.
Bye.